When a limb was shattered on the field, cutting it away quickly often meant the difference between survival and a slow, deadly infection. Imagine a stretcher under cannon smoke, a soldier clutching a ruined arm, and a surgeon who has minutes to decide, save the life, even if it costs the limb. Before antibiotics, wounded tissue and exposed bone were the perfect breeding ground for bacteria carried in dirt, clothing, and shrapnel. Without medicines to halt infection, those wounds could turn into gangrene or sepsis within days, the body itself turning against the injured man. That threat made immediate amputation not cruelty, but medicine. Remove the damaged, contaminated tissue before the whole body was poisoned. The emergency procedure was brutally efficient. A tourniquet stopped blood flow, assistants held the patient steady, and the surgeon used an amputation knife and, when needed, a bone saw to free the limb. Forceps grabbed bone, ligatures, often gut or silk, tied off vessels, and cautery or dressings tried to control bleeding and contamination. Sometimes ether or chloroform eased the pain. Often there was no anesthesia at all, so speed mattered above all. The goal was simple and urgent: control hemorrhage, eliminate crushed tissue, and close the wound to prevent infection. This is why armies trained surgeons to operate on the spot. Waiting hours in contaminated conditions or trying to transport a dying man to a distant hospital usually meant losing him to infection. The same decision that looks harsh in peacetime was a calculated move to stop a spreading threat inside the body. Today, trauma care is different. Sterile operating rooms, imaging, vascular repair, limb-sparing techniques, and powerful antibiotics give teams real options to save both life and limb. Even so, modern combat medicine still respects the old rule: stop bleeding quickly and control contamination, but with tools that turn desperate amputation into rare last resort rather than the immediate choice it once had to be. You'll see how one emergency cut, done fast with simple tools and a clear purpose, kept many soldiers alive when nothing else could, and how that harsh calculus changed as medicine advanced. Why soldiers needed immediate amputation. During the 19th century and later conflicts, soldiers arrived at makeshift operating areas with limbs mangled by bullets, shrapnel, and crushing blows. Wounds shattered bones and tore away skin and muscle, leaving pockets where bacteria could multiply unseen. The damage was not only mechanical. A limb that could no longer get blood flowing tended to die, and that dead tissue became a perfect breeding ground for infection. Surgeons faced a terrifying enemy they could not see: wound infection. Before antibiotics, simple contamination often led to spreading gangrene or overwhelming blood infections. Dirt, clothing fibers, and fragments of metal introduced bacteria deep into a wound, and a trapped pocket of dead tissue gave microbes time and food to grow. Once bacteria moved from the limb into the bloodstream, a soldier could become weak, fevered, confused, and die despite any local care. Tools were simple and the methods direct because speed saved lives. A surgeon in the field reached for a tourniquet first to stop life-threatening bleeding. Knives and scalpel blades made the skin and muscle cuts. A small saw was used to divide bone. Forceps gripped and held vessels while surgeons tied them off with thread to control bleeding. There were two main cutting approaches used in urgent cases: one that removed a cuff of skin to make a neat stump, and another that left a longer flap of skin to cover the end, and the choice depended on how much healthy tissue remained. Anesthesia, when available, could calm the patient, but the operation itself was swift, often measured in minutes rather than hours. The decision to amputate came in a clear, grim order: assess whether the limb could heal and whether infection or crushing had destroyed its blood supply. Apply a tourniquet and cut away the damaged parts. Control bleeding with ligatures. Dress the stump for transport. All the while the surgeon watched for signs that infection had already begun to spread beyond the limb. The whole scene was tense and urgent. A delay could mean the wound fermented into a fatal systemic illness. Modern trauma care has changed much of this story. Today, sterile operating rooms, rapid imaging, blood transfusions, vascular repair techniques, and antibiotics often allow doctors to save limbs that would once have been removed. Still, the basic emergency logic remains. When a limb is a source of unstoppable bleeding or a nest for spreading infection, removal can be the quickest path to saving a life. In every era, the core aim was the same: stop the immediate threat give the rest of the body its best chance to survive. How battlefield surgeons performed operations. During the 19th century and earlier, surgeons on the battlefield made the hard choice to remove a limb because it was often the only way to save a life. A limb smashed by a cannonball or riddled with shrapnel could not be repaired with the tools and medicines available. Bone fragments and torn tissue became breeding grounds for infection, and uncontrolled bleeding could kill within minutes. In simple terms, when the limb itself threatened the patient's survival, amputation became an urgent act of triage. Remove the danger, and there was a chance to keep the person alive. Wounded men were brought to a makeshift operating table or even a barrel. Time was the enemy. An assistant tightened a leather or woven tourniquet high on the limb to slow blood loss, while the surgeon assessed whether the injury was beyond saving. Instruments were laid out plainly: a curved scalpel, artery forceps for grasping and twisting vessels, bone forceps, and a sturdy amputation saw for cutting through bone. Silk or catgut sutures and long needles waited for tying arteries. There was no guarantee of cleanliness. Clothing, dirt, and lead fragments carried microbes that the period did not yet fully understand. That invisible threat made speed essential. The faster the cut and the quicker the ligatures were applied, the lower the immediate risk of fatal hemorrhage and the later risk of severe infection. The operation itself followed a tight, practiced choreography. The tourniquet reduced the blood flow. Why? Why fast surgery saved lives? On battlefields, the two most immediate dangers to a wounded person were uncontrolled bleeding and the rapid onset of infection. A limb torn by a bullet or crushed by metal could lose so much blood that a casualty would collapse within minutes. At the same time, dirt, clothing fibers, and shattered bone left inside the wound invited bacteria that could turn a survivable injury into a fatal one over the next hours or days. Quick removal of the damaged tissue cut off both threats. It stopped life-threatening hemorrhage and removed the dead matter where bacteria thrived. Medics and surgeons made decisions in a hard, fast sequence. A tourniquet went on first to stop the bleeding and buy time. Then the surgeon examined the limb, feeling for a pulse and checking whether bone and soft tissue were too badly damaged to salvage. If saving the leg or arm would risk the whole life, the choice was simple but brutal: amputate now or watch the patient die later. Speed mattered above all. Slow work left more time for bacteria to invade and for the patient to bleed out under the strain. Tools were straightforward and designed for speed. Surgeons used a large amputation knife, a bone saw strong enough to cut through shattered bone, artery forceps to seize and control vessels, and ligature material to tie off arteries quickly. The limb was often supported on an amputation block so the team could work fast and steady. One common approach was to cut through soft tissue rapidly, saw the bone in one motion, and then ligate the bleeding vessels. This method minimized time under stress and reduced exposure of living tissue to contaminated surroundings. A well-placed tourniquet, quick ligature of arteries, and a tight dressing could end the immediate danger. Infection risks before the availability of antibiotics were plain and severe. Deep wounds introduced bacteria that caused tetanus, sepsis, and gas gangrene, infections that spread through tissue and into the blood. Without medicines to kill those microbes, removing the source promptly was the best defense. Amputation eliminated crushed and devitalized tissue where anaerobic bacteria thrived, and it prevented bacterial spread from a limb into the trunk, where treatment options were almost non-existent. Surgeons therefore balanced the immediate sacrifice of a limb against a higher chance of survival for the whole person. Modern trauma care has changed the calculus, briefly and clearly. Today, an operating room offers sterile technique, intravenous antibiotics, blood transfusion, advanced anesthesia, and imaging that can guide limb-saving procedures. Vessels can be repaired, fractures fixed, and soft tissue reconstructed. But the core principle remains the same: control bleeding and remove dead tissue to prevent infection. In the urgent setting of battle or disaster, the historic practice of rapid battlefield amputation illustrates a simple truth of emergency surgery. Acting quickly, with the tools at hand, saved lives when waiting or gentle attempts would not. A shell blows a man to the ground. He clutches a wounded leg, dirt and shrapnel mixed into the break. Minutes feel like hours. On battlefields with no clean rooms, surgeons had to make one hard choice fast: remove a limb to stop a deeper, life-threatening infection. Before antibiotics, a dirty, crushed limb could turn into gangrene or systemic infection within days. That risk and the lack of time or sterile supplies turned amputation into a life-saving gamble. Surgeons worked with simple, brutal tools: the amputation knife for quick incisions, the bone saw to cut through bone, a tight tourniquet to control bleeding, and sometimes cautery or ligatures to tie off vessels. The goal was speed and survival, a swift procedure to remove damaged tissue, seal major blood loss, and get the soldier off the line. Anesthesia, when available, was crude. Sterility was often a hope, not a guarantee. Surgeons learned techniques that minimized time and maximized the chance a patient would live long enough to reach safer care. Today, trauma care is different. Sterile operating theaters, antibiotics, blood transfusions, precise imaging, and staged damage control surgery reduce the need for immediate battlefield amputation and improve survival and limb salvage. But imagining that urgent choice helps us understand why field amputations were common. They were about stopping death, not punishment. Key points: battlefield amputations saved lives by stopping infection and bleeding. Pre-antibiotic infections spread fast. Simple tools and rapid technique were essential. Modern care offers safer alternatives. If this story grabbed you, subscribe and watch our next video, where we explore how antibiotics and blood transfusion transformed battlefield medicine.